Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Bridget Maloney.
And I'm Obstetrician Dr Patrick Maloney.
And today we've invited another doctor onto this show. So we've got 3 people in this room. We're managing it well. We've invited Dr Erin Stewart. Hello, Erin.
Hello.
Hi, Erin.
Now, Erin is a senior registrar in Obstetrics and Gynaecology, and we've invited Erin along because we thought it might be interesting for our listeners to find out what it is that gets you to be an obstetrician and gynaecologist. And so Erin is a wealth of knowledge. She has joined our practice at the Ballarat Women's Clinic, and she comes to us as a 5th-year registrar. So, Erin, I might just start with you.
Yes.
What led you to obstetrics and gynaecology?
Yeah, it's a great question. I think obstetrics and gynaecology in a lot of ways for many trainees and many doctors chooses them. And there's a broad range of different specialties that you can pick from, and we get a lot of exposure to each different specialty as we go through training, especially in the early years, and you just find that one that really connects with you, that you look forward to going to work every day. And that's how I felt about obstetrics and gynaecology. There's something very special about helping women through various different aspects of their life, supporting them through sometimes the most challenging parts of their life. And it was just a very rewarding career path that I could see from very, very early on.
Erin, am I allowed to ask how old you are?
Yes, I'm 34.
34, good. And so I want that just to sink in for everybody. Erin's 34 and still not qualified as a consultant. So
it takes a long time.
So tell us, what are the steps that you've gone through?
Yes, so everyone's journey is a little bit different, but I can talk about my path. So I finished high school at the age of 18, and then I wasn't quite sure that I wanted to be a doctor at that point. So I went and did an undergraduate degree at Melbourne University. It was a science degree, and that was great. It gave us a broad range of exposure to different aspects or areas of science. And I really fell in love with medicine. I had some friends that wanted to pursue medical school. And that was a really long 3 years. There's a lot of study involved to get into medical school. You go through kind of exams and applications. And then I joined a 5-year training, 5-year medical school program, and that was through Monash University. And that was great. And then after you finish medical school, you then go on to 1 year of internship. And I think that's changing a little bit now, and they might even be making that 2 years. But at my stage of training, it was 1 year of internship. The next stage is residency, and that is where the length of time differs for many people. So residency is where you start to pick the area that you think you're going to be interested in. So women's health was that for me. And you can spend 1 year, 2 years, infinite years in that space of residency where you're learning and you're kind of growing in that junior role. And then you decide that you really want to do that specialty, so you apply to the program. And the program in this sense is RANZCOG, so the Royal Australian New Zealand College of Obstetrics and Gynaecology. And they supervise your training over 6 years. So it is a long, long process. So really from the age of 18 to now was all in pursuit of becoming a doctor and becoming an obstetrician gynaecologist. And there's 18 months left of this training, so I'll be 36 when I finish.
Wow. Oh my God, 18 years to become a obstetrician and gynaecologist. That's dedication.
It's a long road.
It's a long road. Yeah, it's a long road.
It is a long road.
Patty, I want to compare that to your journey, but I want to start with, I don't think we've ever asked this question on the podcast. What led you to become an obstetrician and gynaecologist? And you're not allowed to say it's because whoever was in the tea room gave you the best.
That's my favourite answer to it. When you're a medical student, I think that the truth is that a scandalous number of people choose their specialty based on which unit had the best morning tea when they were students. Certainly, what I mean by that is that there are units that make you feel as a junior person at home. and it's and comfortable and sometimes even a useful part of the team, and that could be a very, very valuable thing for recruitment for that specialty. If you get young doctors by their hearts and minds, you never know. But I grew up there are a number of doctors in my family, and I grew up around the medical world. My grandfather was a GP whose surgery was attached to his house, and at the end of the consulting day, if we were visiting there, he would bring all of his surgical instruments in a big steel tray out of the medical practice and into his kitchen.
Got to clean.
Tip alcohol on it and set it on fire, right? And
You wouldn't want to be a doctor.
And I thought that was being a doctor, right? Yeah. When I was a little kid, I saw him like set all the instruments on fire as part of the sterilisation process, and I just thought, this is fantastic. And then, of course, by the time I became a doctor, they'd invented proper sterilisers.
Thank God, not in your kitchen anymore.
I never got to set a thing on fire.
Yeah, for the best.
It is for the best, so I was somewhat familiar with the life of a doctor, perhaps a little bit as a child, and then the route I took was similar to Erin's, except that back when I went through university, it was mostly an undergraduate degree. Which it's moved away from largely since. A couple of Australian universities still do undergraduate medical programs, but most have gone to a postgraduate model, which, to be fair, has its strengths and weaknesses. But one is that it's made it actually take longer.
Taking longer, but if you've got a 38-year-old still finally getting your ticket, I mean, that's ridiculous. I'm going to say it.
I guess there's a lot to learn. And the job takes a lot of judgment and maturity, and that takes a lot of time to develop. But you can't magic that up. But we did have the old system of going in as a school leaver and a 6-year undergraduate degree, which started at 18-ish and finished at 24-ish. And then I spent a few years, as Erin said, that's a variable amount of time that people spend as a general hospital doctor getting experience amongst the various specialties. And I first thought I wanted to be a GP, so I did the postgraduate training in general practice, and then I decided I wanted to be an obstetrician gynaecologist. Reapplied to the specialist program, and went through the 6 years of that, and finished in my about 34. 34.
It is such a long time. I just I bravo to your commitment to be in the profession that you really want to be in. So we've sort of touched on what a fifth-year registrar is, Erin, but what can you and can't you do at a fifth-year level?
Yeah, so the program that RANZCOG supervises or runs, as I said, is a 6-year program, and it's very structured in terms of supervision and independence of practice, and that's for patient safety and care, but also to accelerate your own learning. So as a first-year trainee, for example, you might be able to do simple procedures, and that would be supervised. And at each step along the way, you're kind of signed off, I guess, for that procedure. And that's got to be a supervising consultant is happy that you've reached that standard and that you can independently practice. And you'll, over time, tick off more and more complex things. So in the 5th and 6th year of RANZCOG training, you're really at the pointy end where you're learning the most complex aspects of obstetrics and gynaecology. So whether that be kind of complex cesarean sections and instrumental deliveries, and in gynaecology, it could be hysterectomies, the real complex surgeries. And that's where it's great working with Pat and Kate because they are helping supervise the last 2 years of that training. And there will come a point when I can independently complete those procedures, and that'll be really great.
I hear not that far.
It won't be that far.
Not that far off.
And it's a very structured step-by-step approach to make sure that you're optimising all your training and that you are coming out as a competent and safe doctor. And I feel that myself and my colleagues, we find that structured approach really, really good. You know where you're at, you know where you need to improve, and you know what you're really good at. So,
and also during this time, you were pregnant and now a mum, while still maintaining this massive training load. Like, how did you do that?
Yeah.
Or how are you doing that? Yeah.
Yeah, it's an extremely rewarding journey to become a mum and to also work in women's health. But the crossover time of training is also really at the point where you're aiming to start your family. You're in your late 20s and early 30s, and a lot of, trainees, especially in women's health, are women now coming through, and most of them will start a family at some point. And it is really arduous. I think the two main parts that are the most complex is managing shift work when you've got young children, and that can be weekends, early mornings, late nights, or night shifts. And you've really got to have a strong support base around you to maintain that family harmony and flow whilst also completing your work. But then there's also the quite arduous exam component of training, where we sit a written exam and then an oral exam. And the written exam is kind of middle of training, and that goes for about 6 hours, and you study for 6 months for that exam. And then the oral exam is later on in training, and same thing, a full day of oral exams, and you study for months for that. And that's probably where the main two challenges are, I find. And it's supportive now coming through of being a working mum and being a doctor, which is great. But there's still the complexities of time that come with the inherent shift work and the exams that you have to go through that is really quite challenging. But we all get through it and we're on the other side. So,
well, I want to talk about the workload and compare. I've forgotten, Pat, was it 2011 that you became a fellow? So when did you become an actual consultant, O&G consultant?
8.
2008.
Yeah.
Okay. So in 2008, what did your workload look like? He's counting on his finger. We'll say 2008. Yeah. So what did the training workload look like, and is it much different from what, say, you see Erin's training load?
During my training,
yeah,
I think it was probably much the same. The vast majority of training in O&G in Australia has traditionally been undertaken in big hospitals, and big hospitals run very busy obstetric services that by the nature of the work run 24 hours a day. So it is different to general surgery. It is different to other surgical disciplines and other non-surgical disciplines within the medical world, because those units run busy 24 hours a day. And whilst the general surgical unit or the orthopaedic surgery unit might do some emergency cases in the evening, there aren't that many, even in a big busy hospital, that are running all night. But labour ward ticks on, and the need for intervention in the birth process and caesarean sections and so forth, it ticks on 24 hours. So those jobs are busy. They are intense. Some people love that, the intensity and
adrenaline.
Yeah, and if you talk to a lot of doctors who are perhaps my age and older, sometimes they say they miss that intensity of the early part of their career, where they were at a big city hospital with enormous throughput and acuity. The work that is someone who's seriously unwell who needs attention right now. Yeah. And
part of the training, you do have to be part of a tertiary hospital, don't you? Part of the training has to be completed in a tertiary hospital?
Yeah, some of it has to be, and some of it, and I think once upon a time it probably almost all was. And one of the reasons why we developed our a training spot within our private practice was because we thought we had quite a lot to offer that perhaps a big tertiary hospital, that we could offer a slightly different model to a big tertiary hospital. Yeah.
There was a bit of pushback in New South Wales, wasn't there, about the amount of work, the hours that trainee doctors. Like that might be the biggest change, say, since you went through in 2008 and Erin, is that now there's better boundaries around the hours that a doctor can work. Is that right?
Yeah. I mean, we have in Victoria anyway, I can't speak for New South Wales. In Victoria, we have regulated hours, I guess, in the sense, so you can't work more than 16 hours in a day and you can't work more than 7 days in a row, I believe.
Yay.
And I'm saying that out loud. It
sounds ridiculous.
Quite a lot.
Yeah.
But, labour ward shifts are 14 hours and they do that inherently to improve safety of patients. So you only have 2 handovers or, in a 24-hour period, and handovers are important for passing on information about patients to the oncoming team. So I appreciate why we need to have these long shifts, but they are arduous. However, they are capped in their hours and their numbers. And interestingly, Pat shared a story about what the reason they used to call a resident.
Yeah.
Which was
because you pretty much lived in the hospital.
Yeah.
Oh, you lived there.
Yeah, you
actually lived there.
Back in the day they did, yeah.
Right.
So junior doctors basically lived at the hospital.
And that is very different now. We don't live at the hospital.
No. And what were the requirements? If they wanted you to live at the hospital, could they just call on you at any time?
Yeah. So it was, if we go back to my grandfather's generation, it was kind of a monastic life.
It was a calling, wasn't it?
It was a calling.
Vocational,
It was the least you could do.
Yeah.
Needless to say, it suited men better than women in general. Insofar as the most of the doctors were men back then, and they were young. A hospital resident would have typically been a young single man. So so much has changed that the system has had to come a little bit of the way towards meeting people where they are. Even when I started O&G, the big majority, I'm not sure the exact number, but the big majority of the trainees were men, and now each year the big majority of the trainees are women.
Yeah, 90% plus, isn't it, that are female trainees?
Yeah.
Is that about right?
It is, yeah.
Now, quick question. How many half-used beauty products are currently living in your bathroom drawer? Too many, right? That's where U Beauty comes in. We test everything from supermarket finds to luxury splurges and tell you what's worth it. U Beauty, saving your skin and your wallet. Listen now wherever you get your podcasts.
All right, Pat. So I want some dirt. I want some juice now. So tell me, what surprises you about how the next generation is being trained?
Yeah, that is a cracking question. I've got views on this. I think there are some things that are much better. I think I was probably one of the. If we went back, say, 20 years before my career, it was an old-fashioned sort of master and apprentice model. You watched somebody else do something a few times, then you had a few goes under their supervision, and then they just said, "No, you're good. Off you go. Do it by yourself." And the training programs were long. Because you needed to be exposed to every particular problem at least once. But it was way less organised than it is now. And I think when I went through, it was really getting very organised so that procedure numbers were tabulated, and they said, right, you really, to be doing this procedure like a hysterectomy in private practice, you need to have done so many, and you would have to demonstrate by the end of the training that you had actually done that many. So it was getting better. And that's continued to grow. And I think the training organisations these days are not winging it like they once were. They're aware of the science of teaching things to adults, and they take the learning process very seriously. So I love that. And I also believe that women's health in women's hands is the goal. So the number of women doing our specialty now is excellent, and it's where it should be. There's just a fair bit of change that still needs to happen to make that doable for people. On the downside, I think that trainees in Australia coming out of O&G these days are absolutely world-class obstetricians. In fact, I think they're superb obstetricians by about halfway through their training, and I don't think you're ever any better than the day after you do the exam. You know, you are on top of your game. You're doubtless working in a big tertiary hospital. You're doing tons of obstetrics. Plus, all of the facts and figures are in your brain, ready for the exam. And I think people reach a globally enviable standard as obstetricians. There's always a tension within hospitals, public hospitals that do training, about how much of the job is genuine training for the benefit of the doctor and their development, and how much is what we call service provision, which just means working your butt off on the ward.
Or I say cheap labour.
It's cheap labour,
Yeah.
that's right. And there's no doubt that hospitals and governments rely on junior doctors in training programs to do an awful lot of underpaid work to make the system work. And in my view, we probably don't have that balance right when it comes to the gynaecology side of things. So people become very good obstetricians by learning a lot, but also by doing a lot. And we have not, in my view, we don't have our trainees doing enough gynecological surgeries such that by the end of 6 years of training, people come out, as I said, world-class obstetricians, but they're often still not ready for independent surgical practice as a surgical gynecologist, doing laparoscopies, doing hysterectomies, doing prolapse repairs. They're some of the way towards expertise, but they're not all of the way. And that is a problem for our specialty, and it's something that we're trying to improve. And one of the ways that we here in Ballarat are trying to improve it is to have a senior registrar position in our private practice, chiefly based around mastery of gynecological surgery. I'll just add, and Erin's doing that job with us at the moment, and I think you would agree, Erin, that that to spend at least some of your training in a job with an overwhelming focus on mastery of gynecological surgery, I hope it's useful, and I hope it's everything that we wanted it to be.
Yeah, I completely agree with what Pat said. We've got a lot of training in obstetrics, and we come out quite confident in obstetrics, but gynecology, the numbers of surgical opportunities for trainees are limited, and therefore you can only gain the skills based on the amount of training that you are given. And here at Ballarat Women's Clinic with the senior registrar position, there is a large number of patients that go through and have surgery here with Pat and Kate, and it's fantastic for training to be able to be exposed to those number of cases and to learn with the complexity that comes with them, how to operate appropriately, how to operate safely, and to really get the numbers that mean that when this 6 years of training finishes, that I can confidently come out as an independent gynecology surgeon, as well as an obstetrician that we've been trained quite intensely to become. But it's a very important role, I think, that's come out of Ballarat Women's Clinic in this senior registrar position, because it's what trainees need, and it really has to become a mainstream model ongoing so that the trainees can come out as really proficient, high-quality surgeons. That will happen here at this clinic, but it should be happening for everyone. It should be available to everyone. And at this point in time, it's not as available.
Because we might lose our cheap labour at hospitals.
Well, that's the balance, isn't it? And it's up to the government and the hospitals to juggle all of that. Yeah, but at an individual trainee level, we can say, well, we're doing it slightly differently.
Erin, has there been anything that Pat or other consultants been shocked about at your training in O&G?
I think that the change in training, from what I understand from hearing stories, is probably more about how we support ourselves more from a mental health perspective, how we take a lot of time and energy into making sure that trainees feel supported, and whether or not that occurs, but there's a lot of energy that's put into trying to make sure that trainees feel safe and supported in a lot of times high acuity settings where you're trying to keep people safe and you're trying to manage people appropriately, and having supervision of senior staff is really important for training. We have mentors, for example, that you can go to that aren't clinical mentors. They're just there for your mental health. We have training supervisors. For example, Pat is my training supervisor here. And that gives me the ability to say, go to Pat and say that there's external factors that are making me concerned or stressed and that would therefore impact training. So having that ability to go to someone is really important. It's a long training process. Like we spoke about, a lot of us have families, and managing those intrinsic factors that are just inherent to all of us that can impact training is very important. And I think nowadays we're doing that very well.
Fascinating.
Much better.
Pat,
Much better than it was.
Yeah, well, let's talk about when it was. Is there anything in your training that you're nearly too embarrassed to admit?
I think happened? Just the lack of supervision was one thing that's changed a lot. There's often a fully qualified specialist in a big hospital 24 hours a day in the hospital, and that certainly wasn't the case when I was trainee. Also, there does seem to be more concern for the whole person these days, which was lacking when I did my training. As long as you kept turning up for work, everyone assumed you're fine, and it's hard work. There's a big dedication to the training. The exams are difficult. And the work is occasionally heartbreaking, and people need an eye kept on their mental health and their development as a person during those years. The done thing back in the day was to put your entire life on hold while the training expired and then sort of get on with things after that. And that doesn't suit, to a greater or lesser degree, a workforce these days consisting mostly of women, and it's perfectly normal now to take some time during your training years to start a family, and was very unusual back then and is pretty standard now.
Are you allowed to do your training part-time? Say if you wanted to be at home, can you do part-time training while you're having a family?
Yes, you can.
Because that wasn't a thing back in the day, Pat, was it?
Not really. It was hard to do a small enough amount that was useful, but still have the time counted. And so there was some, but it was the demand probably wasn't as much there.
Yeah.
And then there was the just whether the hospitals could be flexible enough to offer that. Yeah.
Do you both, I mean, you just touched on, Pat, that sometimes it's heartbreaking. We know that, and there's sort of scary things. I think just even being the person in charge is scary, full stop. Did you feel supported, Pat, first during your training? You just sort of mentioned that you had some consultants there, but did you feel supported if you were exposed to a scary moment in your career as a trainee?
Oh, you had to be sharp, and you had to be good at something which it actually took quite a while to get good at, was that you had to be able to predict a major problem from about 50 minutes out, so that if you knew you were going to need the boss to come in, you had a fighting chance to get there before you had to go to theatre or whatever. And knowing what's about to happen is a product of experience. And as a junior doc, it's one thing you don't have, no matter how good you are. So with the bosses off-site, it was hard to predict that. And by the time you got good at predicting it, you didn't need the boss anymore because you were then the boss. So I found that a challenge. And then they're better at that now.
Well, are they, Erin? Because, you know, the hospitals are getting bigger and busier, and there's a lot of pressure. As one of the days that during your working week, you're down at a very busy Melbourne hospital. Do you feel supported during a scary moment? Have you got someone on tap that you can get hold of straight away?
I would say as a consistency throughout training, yes. That we have come a long way in that there generally is a very available consultant who can come in scary moments, I guess, or times where you just need to consult. You know, you need someone to lend an ear and to give advice. So I would say overall, yes, it is very supported, but there are times, given the acuity of the birthing suite or the gynaecology units, that people are managing other concurrent emergencies, and you do need to be able to stand on your own 2 feet and have the confidence to deal with those emergencies. And each time that happens, you learn from it and you get better at it, and you get better at managing stress. I think that's a really big part of training that we don't necessarily have exams on or modules on, that, you know, that you just inherently learn by being exposed to this environment. Surgery, whether that's gynecology or obstetric, is, you know, there's problem solving. You need to be quick and you need to be level-headed with what happens. And, you know, we learn that, but it's easier to learn that when you know there's someone at your back that can help you. Yeah. And I'd say that is overall how the training has been. Yeah.
Great. Pat, is there anything in Erin's training that you're envious of and wish you had have had as a trainee?
I would like to have done the job Erin's got right now. I think I'm envious of an opportunity to do a job with big training, with big numbers. Although I did manage to find a few during my training. I spent a year as a registrar in Albury-Wodonga on the Victoria-New South Wales border in level 3. And I went away knowing nothing, and then I came back knowing tons about gynaecology. Yeah, I probably knew the standard amount about obstetrics, but that was a very gynae-focused job. And I remember coming back to the women's after a year up there, and people were like, "Whoa, where have you been?" There's, you know, so I got those jobs. But one of the really useful things I think about, say, Erin's job right now is she's doing a lot of surgical training right at the end, and I was actually, funny you should ask. I was talking to one of the general surgeons in Ballarat the other day about the potential to have a more exposure of gynecology trainees to some of the other surgical specialties during their training. And she said, "Is there something you'd change about your training?" And I said, "Funny you should say. I would spend 3 months on a general surgical unit if that was a possibility during my training. Yeah, just to see the way other surgeons who aren't gynecologists deal with bowel, or the way a urologist deals with the bladder on a daily basis. I think that could be a hugely. This is the answer to a separate question. This isn't what you asked me, but I guess I'm trying to make the point. We could do even better.
Yeah.
And why not aim for the best?
Gynecology has sat apart as this sort of discipline separate from the rest of surgery, despite being a highly surgical job. And that's just a historical difference in that it used to exist really quite outside the broader surgical world. And it's also because historically women's health was treated as a boutique problem that weirdly affected 50% of the people in the entire world. Whereas urology, if that's a male equivalent, is more at home within the rest of the surgical world than gynecology. Is that right?
Yes.
Yeah. So we could do even better.
There is a call from Vinay Roche, who's I've forgotten what he's the boss of something in the college. In the college, and that's his call as well. He's saying that why do gynecology patients sit on their own ward? They should be sitting on a surgical ward in a way, because they've got the same recovery and issues that other surgical patients have, but it's always been sort of a bit apart. In that, remember, we've talked about this before, that back in the day, people, a male would take the title of Mr. if they were a surgeon, but gynecologists were never offered or awarded the title Mr. That you were always doctor, because it was seen as a different specialty. Different thing.
Yeah, so that is interesting, because I would say that almost all of my gynecology patients have coming into the hospital for, say, an endometriosis operation or a hysterectomy or a prolapse repair, have more in common with someone having a gallbladder than they do with someone having a baby. That is not the same thing. And of course, these are the arguments that are commonly trotted out when they talk about whether we should be 2 specialties, not 1. And Erin, I don't know what the view of that amongst trainees is. Would you have a view on that?
Yes, I think most trainees are now they're realising anyway that there are benefits to splitting training at some point. I think the problem probably is that we're looking at women's health as, both obstetrics and gynecology, but we know that women's health starts from a really young age and extends all the way throughout life. And there are different complexities and different managements that they need throughout those stages. And really the training that's needed to provide care throughout someone's entire lifespan, when you think of the management needed, is so large, and that 6 years is just not actually enough. I don't. It sounds crazy to say now, but if we did find a point where you got exposure early on to both specialties, or obstetrics and gynecology, and then at some point it did split so that you could target and you could specialise in that area, whether that obstetrics or gynecology, you would increase the amount of numbers and the exposure for the doctor, and therefore increase the level of care that patient could be provided with, I believe, in the current training model that we've got. And I think most trainees that, we have general conversations with can see the benefit of that, because we all want to be the best that we can possibly be. We don't come into training wanting to come out not being independent in everything. And I think it's important that if that's our goal, we need to find a space where we can learn appropriately in both areas.
So I'm going to go to the same question I asked Pat. Is there anything that you envy in Pat's training back in the day that you wish you had?
Yes, I think it's the exposure and the numbers, and I can see this as a positive and negative, but when you are exposed to high volumes and there's not as many, I guess, doctors there on a roster system, and you've got to work all the time, constantly, there is a benefit to that in terms of the training that you get and how quickly you upskill and how quickly you become independent. I don't necessarily know that I want that rostering system, but it does come with benefits. And I think hearing stories of consultants say that they stopped counting the number of forceps at 1,000 because, that was enough. They decided they didn't need to keep counting for their logbook. And you think those numbers are so huge, and the amount that you learn from the numbers that you do, I think is very different to our training now. And it would be good in some way to be exposed to those numbers. But the job that we're doing now here at Ballarat Women's Clinic is really probably the best of both worlds, in the sense that you're exposed to really high numbers without necessarily working 130 hours.
Yeah, still having a lifestyle.
Yeah, exactly.
I don't know. Lifestyle is still to be debated. Depends whether you ask the wife, aka me.
You grew up in a golden time of smash hits and Dolly Doctor. You copied Baby's dance moves and Dirty Dancing, taped Charlene and Scott's wedding, stacked Madonna bracelets up your arm, learned to drive with no power steering. You were pretty fucking cool. But now, no one's talking about you anymore. Not the media, not the culture, not the algorithm. You've been made to feel invisible, which is rude, honestly. Introducing Unleashed, a new Mamma Mia podcast for every Gen X woman who needs a laugh. It's funny, it's honest, it's the group chat that you actually want in your ears. And it's coming soon. Go to your podcast app, search Unleashed, and hit follow now before you forget.
All right, Pat, do you think that the job's changed much in the time between when you became a fellow in 2008 to now?
Yeah, it certainly has changed. So if we look at obstetrics, there's really interesting tension within obstetrics, that there's a constant move towards technology, towards scientific intervention, trying to get greater and greater and greater outcomes. But an enormous amount of improvement was made in safety for women and babies over the 20th century, and now we've got a little bit of a law of diminishing returns situation where we have to interfere a whole lot more to get tiny extra percentages of safety. And one of the things that's changed, I think, since I did my training, is that back then that was just considered the way it was done. If you had a study that showed that if you interfered in a pregnancy or a labour in a way that gave a 1% benefit, then everyone would just start doing that, And I think now, not so much in the profession, but in the broader community, people are saying, well, hang on a minute. Is that what we want? Do we want you to continually medicalise and scientificalise this process? Potentially at the expense of having an unmedicated, non-interventional birth. So, that is changing, and people these days are a lot more aware, I think, of what women actually want, and what the community really wants. What's our role in that? And then over on gynecology, it's just technology. It just keeps developing and developing and developing. When I trained at Erin's level doing laparoscopic hysterectomies, the ligaments and supports either side of the uterus, we used to use a bowel stapler, that a general surgeon would use to do a bowel resection. This sort of automatic stapling device, and that was designed to go over bowel, but we would just use it either side of the uterus to get the ligaments and vessels out of the way. And it had some pros and cons, but it was an example of the idea of doing the operation laparoscopically, surging ahead of the gadgets. We didn't have the gadgets we really needed to do that operation. So then they invented the vessel sealers, a much more elegant device that you could clamp down on some tissue. It would seal it really reliably, and then you would cut it with scissors. And then they invented better vessel sealers that would seal it and cut it in one go. So the operation became faster and more efficient and more doable. And then this, and then that, and now the robot. Right, so there's technology on the gynae side, and getting back to what we were saying before about remaining a true expert in both. I think that's getting harder.
Agree.
What service models, Erin, do you think, or even types of treatment, do you think will change over the span of your career?
Yeah, I think touching on what Pat said, I think if we look at gynecology, I think we've got leaps and bounds to go in terms of like robotic surgeries that we can offer women, which is going to be a really interesting space to move into, because it's a hard thing to describe, but there's a lot of fatigue that comes with surgery, and it's difficult to describe to people that even though you're standing still,
you're concentrating that whole time,
and you're not moving, you physically get really fatigued after long procedures.
And stand on one leg.
And you stand on one leg.
Well, you shouldn't stand on one leg. I'm sure someone from OH&S has said, okay, stand on both legs, people.
We stand tippy toes.
When I'm teaching, I don't know, it's like, when you're doing some skill when you're a child and you stick your tongue out.
Yeah.
When I'm teaching, the dual role of doing my job plus keeping an eye on the person I'm teaching, causes this motor overflow where I stand on one leg, which is fine until you try and walk away after 2 hours, and you find that
Yes.
And you stand on your tippy toes.
I stand on my tippy toes, yes. People ask me if I need a step, and Pat says no, she doesn't.
She's fine.
She's fine. She just likes to, that's where her nervous system sends her, back up on her tippy toes.
But I think, robotics will be an amazing leap forward and advancement for gynecology, because, that lack of fatigue that comes with being able to sit down and manipulate the instruments really easily, the ergonomics of that is going to improve so much. It's going to improve efficiency. It's going to improve the amount of patients that we can care for. It's going to improve safety. And I think that's going to be a really interesting advancement going forward over my career as to how we go from, just learning robotics to really incorporating that into a ongoing practice sense.
And in obstetrics, if we go to service models, like, if say it does end up splitting and we end up with an obstetric stream and a gynecology stream, where does that leave us? Do we go down more of a midwifery-led obstetrics? What can you sort of see happening?
I think there'll always be a role for both, and obstetrics is such an interesting field because we've had this for thousands and thousands of years, and I think we can see now that there's a real importance of joint collaborative care. And I think we do that well. And I agree with Pat in the sense that there's a lot that you hear, social media and in the community about the risks and benefits of intervention and how that impacts women and their journeys. But I think ultimately potentially the social media aspect and having multitudes of opinions is going to be an interesting space moving forward, and making sure that we're always reading or taking on board peer-reviewed evidence-based medicine, I think will be best for safety going forward, whilst also making sure that we collaborate appropriately with all multidisciplinary care, like with midwifery, ongoing.
Well, that leads me to my question I wanted to ask of you, Pat, and is that what have you've been right in the thick of the rise of social media. How do you think that that's impacted your practice or even the opinion of the general population about obstetrics?
Yeah, it's a very good question. I think regardless of what career you're in, discipline you're in, people would have views about how social media has helped, and also frustrations about how it's been a problem at some point or another. And I think overall for us in medicine, social media has had an effect of democratizing the medical knowledge. And we haven't always won. That hasn't always been done terrifically well, but it's a necessary part of healthcare in this century. And the old model of the doctor as the sage who you went to and said, "I've got this, and you should do this, go away," that is gone. And social media has been really valuable in democratizing that situation, so that the knowledge is there for whoever wants it. The role of the doctor needs to be able to pivot and grow in that and develop in that world, so that if people come to you with a really high amount of knowledge because they've read good stuff, quality things on the internet, then you just need to be able to pivot very quickly and say, right, you know tons. I interrupt people and say, are you from a healthcare background? Right? Because if they are, then they don't need me over-explaining things. They already know it, right? If someone's a nurse or a midwife, my God, they know it. So they don't need me over-explaining it. And then if they say no, and yet they're clearly talking from a sophisticated knowledge base when they come in with their problem, then I assume that they've got that knowledge base from somewhere else. Throw in a few questions to explore the quality of that. And then I think we as docs need to be good at not getting angry at people about if they have come in with the wrong idea from social media, like something that's just factually incorrect, because it can be bloody hard to tell if you're not an expert.
It definitely can.
So we need to be able to nut out quickly in an agile way where people are at. And the other thing, I know something that's dear to your heart, Bridget, is that as experts in the field, we need to use these to get an expert opinion out there, so that if someone is a patient or a potential patient thinking about starting a family, so that they are hearing a broad range of voices on the socials, and if they want to seek out breadth, the model of care advised by the obstetric expert doctor is available to them through that channel.
Yeah, I think when we first started the podcast and even the Grow My Baby program, it was like, if not us, then who? Because we could see that there was a big void. And if there's a void, it gets filled. That's just the laws of the universe, isn't it? Yeah. So we thought, well, why not us? So, that's how we started. All right, I want to talk to you both about what really makes you feel excited about modern obstetrics. You go first, Pat.
I've always been involved in teaching, and I love teaching, and I don't mind whether I'm teaching a senior registrar, a junior doc, a junior burger, as I call it.
Oh, yeah, we forgot I was going to introduce Erin as a junior burger, because we've used that in our podcast for years, haven't we? Erin is our junior burger.
She's a bit senior to be called a junior burger.
Okay, so she's what's the next one up?
Senior burger.
Senior burger, okay.
So there's, whether or a medical student or whoever, I like teaching. And so I get a buzz out of teaching in obstetrics. And I don't mean teaching as part of my job. I mean teaching the patients. I like it when people say, "Why are we doing this?" And I say,
Yeah.
And I love that moment that people go, okay, I never knew that.
Yeah.
Sometimes people have assumed that we're interfering for fun.
Yeah.
That there isn't a basis behind some of the things. And let's face it, there are some corners of the internet that say exactly that to people, that we're interfering for no reason, and that's not true. A proposed intervention in obstetrics should have behind it an excellent evidence base, and I don't think the problem is that people out there don't want excellent care. It's that they don't sometimes understand what we're getting at, what we're trying to help with, how crap things used to be.
Yeah.
So I like teaching within that space, and the more you do it, the less awkward it seems.
Also, I think we started the podcast in 2020, 19, 21, anyway, around that time. And even our listener base has increased in their knowledge. And it's not just because they're listening to The Kick, although I'd like to claim that. I think in general people are probably getting a little bit more educated.
Yeah, you can tell because the questions on the Q&As, they're better questions.
Yeah, they're better.
Great.
So they used to, the very early ones were nowhere near as sophisticated as the questions we get now. Yeah.
Or maybe people are self-selecting because they're getting more sophisticated, so they feel they can't ask their simple questions, which is not what we want either.
We're open to all questions. Bring them on.
All right, Erin, is there something about modern obstetrics that excites you?
I think the one of the really interesting aspects going forward is that our demographic of pregnant women are changing. So people are getting slightly older. They're going through IVF treatments. They have different complexities to their life that they may have not had 50 years ago. And with that comes inherent difficulties within pregnancy and the complexity of care that you have to provide to people. And I think that is really interesting in finding that balance of keeping people safe in their pregnancy and providing them a really safe kind of care plan. Whilst also understanding that these things are changing. Like people getting older, there's increased risk of preeclampsia and gestational diabetes, and I think that is going to be a really interesting space going forward, how we manage the demographic change.
All right, I think I might wrap up with one last question, and that is, if someone comes to you and they're already either a young doctor wondering what specialty that they would go into, or they're a school leaver thinking about going to become a doctor in the first place, what would you tell them? A big resounding go for it, or would you go, yeah, it's a long road? What would you say?
I would say go for it. It's a fantastic career. You really get to help people. You meet a whole range of different colleagues and specialties, and it's hard and it's long. But if you're going to go through something that's hard and long, you may as well go and do something that's so rewarding. And I would encourage people to do it. I think it's a great career. It's good to know what you're in for, I think is important. But I wouldn't change a thing. I would still be here in the same seat doing the same thing if I had my time again. So definitely go for it.
How exciting. What about you, Pat? I'm going to put a parameter around it and say it's one of our 4 boys. They've come to you and they say, look, I think I might become a doctor. What would you say?
Which one is it?
I have none of them listened to that answer.
I would echo what Erin said. It's a cracking job. It is a really good job. It's interesting. It has a unique mix of science and humanity, and it is a good, fulfilling career. There's probably easier ways to make money, but people go fine financially as a doctor. It's a good job, and sometimes retired old doctors say, "Oh, don't do that. There's an easier way to make a living," or whatever. I think maybe by the time you've got that point of view, you probably should retire.
Yeah.
Because I'm 52. I don't remotely have. I look forward to going to work.
Yeah.
It is a good job. And in obstetrics in particular, there's this endlessly renewing supply of bright-eyed young people who come to see you, with starting a family in their heart, and it keeps you in touch with your old self. You know, you can see it, you're looking after young, idealistic people with a dream of a family. That is nice. Yeah.
It is nice. And like vicariously, I get a bit of that too when we're in the clinic. I get a little snuggle of a baby and I get all clucky again and think, well, that ship has sailed.
That ship has sailed, but
it's still nice.
Yeah, but it's just like a little reminder of what that phase of your life was like, which was an exciting and optimistic time.
Yeah.
Yeah.
All right, everyone. I hope you've really enjoyed that. I've loved talking to Erin and Pat about this. It's sort of a bit off our normal programming, and I expect somebody's picked this because either they're just fascinated by obstetrics as a career, want to know all about their obstetrician doctor, or perhaps, they know somebody that wants to get into medicine and perhaps you could send that to them and share the talk, a real talk. That was really good. I really enjoyed it.
Thanks so much for having me.
All right, well, until next week, keep well, keep safe, keep growing those babies, and we'll be in your ears next week.
Thanks for listening, everybody.
Bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.